Hello, and thank you for joining us for this OncLive peer exchange. We are experiencing unprecedented progress in treating advanced non-small cell lung cancer as the rapid development of novel targeted and immuno-oncology agents continues to transform the landscape of therapy. In this OncLive peer exchange discussion, clinical perspectives on new data in advanced non-small cell lung cancer, a review of abstracts from the 2018 World Conference on Lung Cancer, I'm joined by an international panel of experts in thoracic oncology. Today we will cover several important studies being presented at this year's meeting and will share insight on the implications for your clinical practice. I'm Dr. Benjamin Levy. I'm an assistant professor of oncology and clinical director of medical oncology at the Johns Hopkins Sidney Kimmel Cancer Center at Sibley Memorial Hospital in Washington, D.C. Dr. Solange Peters, head of medical oncology at the Lausanne University Hospital. Dr. David Planchard, an associate professor of medicine and the head of thoracic cancer group at the Gustave Roussy in Vouligy, France. Dr. Sanjay Popat, a consultant thoracic medical oncologist at the Royal Marsden Hospital and reader in cancer medicine at Imperial College in London, England. And Dr. Suresh Ramalingam, professor of hematology and medical oncology at the Winship Cancer Institute at Emory University in Atlanta, Georgia. Thank you so much for joining us. Let's begin. So we'll start out in the stage 3 space, the locally advanced non-small cell lung cancer space, a space where we've really been begging for new therapies for quite a while. Of course, immunotherapy first landed in the advanced stage setting in second line. It's now being moved up to first line. And now we're seeing emerging data with the use of immunotherapy in the locally advanced setting, specifically with PACIFIC and the use of durvalumab. Solange, you want to take us through just a high-level overview of the PACIFIC trial? It was recently published in the New England Journal of Medicine, but now we have some updates here at World Lung that continue to alter the treatment landscape for these patients.
Yeah, absolutely. I think the data we will be seeing during this meeting and discussing together confirm the benefit of the strategy in stage 3. I agree with you. We've been trying many things, various chemo, various radiotherapy, some vaccines. We've been trying many things in stage 3 without any advance. And now we have this PACIFIC, quite simple trial, real-life trial. This is about receiving radiochemo concurrently. 50 grays, 2 cycles of chemo, so very, I would say, minimal denominator of the regimen. And these patients, once they have completed this induction treatment or standard of care treatment, I would even say, they are randomized between placebo, the usual way to do, and durvalumab for a year. And the first publication in New England was showing an unprecedented benefit of almost 11 months of PFS, reaching 17 months or something that we were not used to observe in non-small cell lung cancer. So a gap between the observation arm and the experimental arm, which was absolutely amazing. The shape of the curve was very attractive, but of course the main criticism to this trial was that in a curative setting, when your aim is to cure the patients, what you need to show is a difference in overall survival. It's probably a good way to think also for the adjuvant trials. And at this meeting, that's what will be presented, the overall survival. And what is very interesting is really to discuss the fact that it confirms and the overall survival is strongly positive as compared to the standard arm to the observation. So basically, based on that, I think we have the final confirmation that there's something, I would even say the magnitude of benefit is showing that there's something interesting in trying to combine various modalities. Maybe it's about radiotherapy. We all think about the immunogenic cell death. You create an environment very prone to be responsive to immunotherapy maybe. But there's something really to grab here in a really multimodal treatment, 3 modalities in terms of gaining cure or at least survival time for these patients. It's very important to stress a last element which will be important in Europe. In many of these patients, no tissue was available. It's stage 3 disease, so it's difficult to have enough tissue to really assess biomarkers. So this result has been, I would say, provided to the whole comers non-small cell lung cancer, and the ITT population is positive for survival. Then if you look at subgroups, you face the problematic of potentially not having good data in trying to differentiate subgroups there. And I know it's going to be a matter of debate about PD-L1, about accessibility of tissue, but basically this trial was aiming at looking at a very simple question, an ITT population, survival better or not, and the answer is yes.
Yeah, I think we got definitive answers. Yeah. I think all of us can agree, pretty impressive results. I think also something that we forget, I think there were some concerns about toxicity, layering in immunotherapy right after radiation, and would we see that pneumonitis or any other immune-related adverse events? We didn't see that in this trial.
No excess. I mean, you have to know that when you give radiochemotherapies, there's a certain number of radiation-induced pneumonitis. When you give immunotherapy, it happens sometimes that you have immune-related pneumonitis, but the risk was to imagine that both phenomenon would increase or give rise to an excess of lung toxicity, and it's not the case. It's not the case in most of the trials where we try to combine radiation on the lung and immunotherapy. It looks like the mechanistic behind is not cumulative or it's not synergistic in the bad way, right? It's just the fact that it happens sometimes that radiation gives rise to some pneumonitis.